Okay, so we're going to go ahead and get started now with this review. We're going to be reviewing chapter 13, where we talked about infection and disease. Then we'll review chapter 14, which is our epidemiology chapter. And then we'll go over our most missed topics and the questions that were associated with those most missed topics in the past for past students. And then if anybody's here, I'll be happy to field any questions. And of course, if you are watching this as a recording, you can always email me if you have any questions about any of this stuff. So let's get started. All right. First, starting with chapter 13, which is about infection and disease. Our key concepts that we covered for this chapter, we have infection and defining what infection is. This is anytime we have pathogenic organisms invading and multiplying. And so that's the important part, is that you have the invasion and the multiplication involved in that. You can have infection without pathology or disease. And disease and pathology result from damage done during the disease. And we consider disease to be any deviation from the health. And then disease can be caused by things other than infectious organisms. Of course, you can have disease caused by cancer or from genetic defects or metabolically related things like what we see with type 2 diabetes. That these things are all still diseases, but that the focus of this course, of course, is to be focusing on infectious diseases. And so those are disease as a result of infection. And so pathology results because of the damage done from that infection. And so that's what would present to us as individuals as disease. So that deviation from health is our disease there. Our resident microbes, of course, are going to be introduced into our body. We mentioned that you'll have your first introductions in utero, but that you'll have your primary seeding of your microbiome through the birth canal, as well as through your introduction through breast milk, and then the environment around you, whether that's from your caregivers who you have direct contact with, or from your environment like your pets, or just literal physical environment like the ground and the air we breathe and the things that we touch and come into contact with. And then we also mentioned about microbial antagonism. The microbial antagonism is basically the effects and the protection that we get from our resident microbiome. And so remember that the combination of your whole body plus your microbiome, that the term for that was the holobiont. Okay, excuse me. And that the microbial antagonism refers to the fact that our microbiome takes up our stadium seats, right? So they are essentially taking up all of those empty spots in our body that pathogens could potentially attach to and then establish an infection in those sites. And then presentation of that infection, and then development of the disease after that fact. And so our resident microbiome can protect from that as a result of just taking up the stadium seats, taking up the spots, as well as they can produce waste products, other chemicals, and signaling molecules, as well as like antimicrobial peptides and all sorts of stuff that could literally also participate in fighting off potential pathogens and infection-causing disease. And so our microbiome works very well within itself and with each other to maintain the balance that is intended for a healthy, functioning body. And they're just doing their job by being there and taking up those spots and using the nutrients and taking them away from potential pathogens. But that function of that side of our microbiome, that's what constitutes microbial antagonism. A true pathogen, this is a guy, so we did this one. We're on this one now. A true pathogen is something that causes disease even in healthy people with healthy immune systems. Here we are talking about things like COVID or flu. These are diseases that you can get even as an otherwise healthy individual with an otherwise healthy immune system. True pathogens cause disease even in our healthy people, whereas, so those are true pathogens. And we have opportunistic pathogens. These guys will cause disease when the host defenses are compromised or when they wind up somewhere where they shouldn't be. So an example of taking advantage of our host defenses being compromised, an example would be literally like if you had just fallen and stumbled and got a scrape in your knee, and bacteria from the environment, they don't normally cause disease, but they will take the opportunity to cause an infection in your scraped knee, your broken tissue where that host defense has been broken. Our barriers that are caused by our outer layers of our skin have been broken. That compromises your defense. And these guys can then cause an infection in your, scraped knee. And that would be an opportunistic pathogen. They don't cause disease otherwise when your defenses are up, right? But they can take the opportunity to do that when they have compromised that host infection. And we also have the guys that will wind up somewhere where they shouldn't be. Some of these guys can kind of cross both sides of it at the same time. Obviously, if you scrape your knee, your host defenses are compromised and we have microbes winding up where they shouldn't be. But we can have microbes wind up where they shouldn't be, where your defenses aren't compromised as well. And that our biggest example of that was like a urinary tract infection. The E. coli from the colon moving into the urinary tract where they shouldn't be. We didn't compromise our host defense with that, but we did have an introduction of microbes where they shouldn't be. E. coli doesn't belong in your urinary tract. It belongs in your colon. And so when it moves into that urinary tract, we can get an opportunistic infection from that opportunistic pathogen, which would be E. coli in that case. Virulence is a term that talks about the degree of pathogenicity. How bad is the damage being caused by this infection? So how bad is it? So pathogenicity is the fact that you have damage caused by the infection. The degree of pathogenicity, how bad is that damage? And that term for that is virulence. And so it's a measure. And so a virulence factor is anything, is anything that would be involved in causing that virulence. So anything that would lead to the development of the worsening of the effects of the infection. Anything that does damage to the host in favor of the pathogen is our definition that we have here. So this would include things that like capsule that helps evade phagocytosis. This would include something like flagella that helps with moving around within the host. It could be making toxins or enzymes that help break down the host defenses or cause damage to the host. These are all virulence factors. Our organisms have to be able to get in to our bodies to cause these infections. So these are portals of entry. So this is just how the organism gets into that site to cause the infection. Our infections can be exogenous or endogenous. Exogenous, it came from outside of the body. And then endogenous, it came from inside the body. So these are the two types of infections that you can have. It has to come from somewhere. So if you got your urinary tract infection from the E. coli from your own colon, that's an endogenous infection. If you fell and scraped your knee and bacteria got into that site and you didn't clean it well and it ended up leading to an infection, and then maybe inflammation and pus and things like that develop, leading to disease, and that would be an exogenous infection. All of our organisms, once they get into our body, have to be able to establish the infection somehow. And so this involves attaching or adhesion. It also includes the process of quorum sensing, so the ability of organisms involved in biofilms to communicate with each other so they can basically establish how healthy the overall biofilm is doing. And then if that organism wanted to leave that biofilm situation or not, and then migrate to other areas of the body or something like that. So attaching and adhesion in bacteria, this is primarily talking about things like fimbriae, which were our attachments, basically for, gosh, my mucus levels today are a little too high. For attaching for fimbriae, these are appendages on the bacterial cell that are used for attachment to surfaces. We also know about our capsule or our slime layers, which are that sticky sugar-based coating on the outside of our bacteria, which could potentially, this isn't what I wanted, which could potentially allow for them to stick to surfaces as well as evading our phagocytes, right? But they're also used for attachment. Just trying to bring up my chat. So in case that you guys have anything to say, I can see it. And then we have for viruses, they have those spike proteins that will be literal, like they're like a key that interact with a specific lock that allow them into certain cells or attach to the surface of certain cells and things like that. So that's the viral spike proteins. Bacteria can have similar proteins on their surface that allow them to attach to surfaces or sometimes even get into cells as well. They aren't called viral spike proteins, but they still could have a similar function. And that so all of these proteins for attachment, the fimbriae for attachment, the capsules or slime layers for attachment, all would fall into this category for attaching and adhesion. And so you got to get to your stadium seat and then stay there, right? So it's the idea. Finding the stadium seat where you're going to sit down as a pathogen and then taking up other stadium seats around you. You first got to get to your stadium seat and stay there. After you've gotten to your stadium seat and you've picked your position and where you're going to establish your infection, you've got to survive the host defenses. So these would include things that might fall into the category of anti-phagocytic factors. And these are all going to be considered virulence factors because they're going to help in establishing the disease, right? So our anti-phagocytic factors would include like having the capsule, which we already know helps us sneak away, like escape being held on to by the white blood cells that are going to eat you up. So having a capsule helps with that. You could also be an organism that has, basically evolved to live inside of the phagocyte and not be killed by the phagocyte. So that's another thing. You also could be an organism that, when you get inside of a phagocyte, kills the phagocyte, so the white blood cell. So you can either evade being eaten by a white blood cell, you could survive being in the white blood cell, or you might kill the white blood cell. And these are different categories of those anti-phagocytic factors. In order to then cause disease, because this is the part that affects us as the organism being infected, and then, of course, being presented as disease, which is our deviation from health as a result of the damage being done during that infection process. So what things lead to causing disease? All of those virulence factors can have a play in that. So this could be exo and endotoxins. And exo, anytime we're talking about exo, always going to be referring to outside of a cell. So an exotoxin is anything that is secreted by our bacteria outside of the bacteria. So they make it in the cell and then they push it out of the cell. Anything that would lead to damage of the host that they're infecting is an exotoxin. And so that can include our exoenzymes. So our exoenzymes, obviously enzymes that are pushed out of the bacterial cell that are designed to break down certain molecules of the host that they're infecting. We talked about collagenase being an enzyme the bacteria can make that can break down your collagen. They can break down your hyaluronic acid that is part of your extracellular matrix. So your collagen, your hyaluronic acid, and there's other molecules involved in your extracellular matrix that helps hold your cells together, and that's what makes up tissues. And then, of course, that's ultimately your tissues are going to make up your organs. They can break down these junctions to a degree that allows the bacteria to get deeper into the tissues. And so any of those proteins that they make that leads to like digesting down those molecules, those are going to be enzymes. And so those are exoenzymes because they're secreted by those organisms. And so because they're also causing damage to the host, our exoenzymes also count as exotoxins, right? So think of exoenzymes as being a kind of a subcategory of exotoxins, because there are other exotoxins that are not enzymes. They're not breaking anything down necessarily, but they can still lead to damage within the host and presentation of pathology. So an example of that would be the exotoxin made by Clostridium botulinum, which is the botulinum toxin, which we know is used as Botox. This is a toxin that is not an enzyme, but that blocks the release of acetylcholine during our nerve impulses that allows for movement of muscle. And that it blocks that. And so it leads to flaccid paralysis, which is our typical ideology of what paralysis is. And so that's a that's an exotoxin. That is not an exoenzyme, right? And we can also have organisms that have molecules on their surface or molecules that they might produce that are going to be leading to excessive host response. Endotoxin is a great example of that. So endotoxin is one of those things where, let me switch to this really quick. Clear this up just for a second. Excuse me, endotoxin. So inside toxin. So these are toxins that are part of our gram-negative outer membrane. And they're part of the outer membrane. They're called the lipopolysaccharide. And they serve a function on the outer membrane for just the cells themselves. But this is also something that our body recognizes as foreign. And as a result, we would mount an immune response leading to inflammation. And inflammation leads to damage within our bodies. It's like because we're multicellular organisms, we know that our bodies will be able to regenerate the cells that are damaged. And so our bodies are willing to sacrifice cells within it for the safety of the whole. And so that's why a lot of our immune responses can lead to damage of the host, like the host cells. And so these endotoxins, which are part of the gram-negative, so that's why they are endo, and they're not secreted by gram-negatives, right? They're not expelled outside of the cell. They're part of the cell. And so these gram-negative cells can just be existing in our body, or they could have killed or broken down somehow. And then our response to the presence of those endotoxins, our immune system can be triggered very, very strongly in response to that. So that just the presence of endotoxin can cause an excessive host response unless there's something in play with our response to that organism to help our immune system be regulated, down-regulated from that over response. So endotoxin is a good example of causing an excessive host response. There's plenty of other factors that bacteria, viruses, fungi, and protozoa, and even helminths have in their bodies that can, or their cells, that can lead to our excessive host response that plays into causing disease. But I just feel like LPS, the endotoxin, is a very good example of that. It's something that when your body sees it, immediately triggers an immune response. And if you see LPS in the bloodstream, can lead to the development of shock, which could even be deadly in some people. So we have gotten into the body through our portal of entry. We've attached or adhered to a site. We have to survive our host defenses. And then the enzymes and toxins and other products that we make as a pathogen leads to the causing of disease. Once we started causing disease, there's usually a pattern of infection within the bodies that we can kind of group these infections into. These patterns of infection include a localized infection, which would like be a boil, or like if you scraped your knee, just that site where that infected wound is, that's a localized infection. A systemic infection is whenever you have that pathogen moving throughout a good portion of the tissues of the body. So it's not localized to one area, but has spread throughout the entire body or a good portion of it. This is especially true whenever we see bloodstream infections because it will transmit the organism throughout the bloodstream. And then we have focal infections. A focal infection is whenever you have a localized infection that has moved to another site of the body, but we haven't moved throughout the whole body yet. So a couple examples of this might be you have a sinus infection or you have a cold that's in your upper respiratory tract. And then the mucus and the drainage and everything like that can lead to a lower respiratory tract infection, maybe pneumonia and something like that. That could be an example of a focal infection. You don't have it systemically. The organism isn't found throughout your whole body, but that the organism is found in these kind of two areas. A mixed infection means that we have an infection caused by more than one organism. And we have primary and secondary infections. A primary infection is like that original site of infection, whereas a secondary infection results because the first infection happened. So our example in our class was you got influenza and you have symptoms of flu, which can present as basically a systemic infection, but that because the flu is causing damage to tissues in your body, Now, other organisms, including opportunistic pathogens, even the ones that already live in our sinus cavity, like Streptococcus pneumoniae, which is a very common one, can move into the lungs where it doesn't belong and then lead to the development of pneumonia. And so it's a different infection, right? It's not the influenza virus. It's a second infection. It's a second organism. And so that happened as a result of having the first infection. That would be a secondary infection. Acute illness is whenever we have rapid onset of the symptoms, and they're usually pretty strong presentation of the symptoms and signs, but we don't have it being very long lived. So acute infections are usually pretty short-lived versus chronic infections. You have a slower progression of the disease. Often the signs and symptoms are a little bit more muted compared to acute infections, and chronic infections are long-lasting. They can even be lifelong. So that we can categorize disease or infection that way as well. And that brings us to talking about the differences between signs and symptoms. A sign is something that you can measure and verify. So this is what we call objective. So these are those situations where you can measure your patient's fever and verify they have a fever. You can palpate that they have swollen lymph nodes. You can do blood tests to show that they have elevated white blood cell counts. You can see that they're vomiting. You can see that they have diarrhea. These are all signs, whereas symptoms are usually subjective and they are reported. So you can say that this person is displaying what you would expect to see from somebody in pain, but you can't actually verify that the pain is there or how like high or low their pain levels really are. And so those would be symptoms. And then we have syndromes, which is basically a disease that is based upon certain signs and symptoms and not so much based on what's causing the infection. And so I feel like our most basic explanation for that one would be a common cold. So the common cold is defined as having a runny nose, maybe a little bit of stuffy nose. You have rhinitis, which is your inflammation in your runny nose. You might have a little bit of pharyngitis, which would be your sore throat. You might have a very low grade fever. You might have a little bit of fatigue, maybe a cough and things like that versus and then so we might say that that's a common cold. And those common colds can be caused by like 200 different viruses. And it's almost always caused by a virus, but we could actually even say that certain bacterial infections are causing a common cold if they have the same signs or symptoms. So common cold is defined by its signs and symptoms. Same thing with meningitis. Meningitis is defined by its signs and symptoms, not by its cause. And so if you have inflammation of the meninges, which are the covering of the brain, that's the actual definition of meningitis. And then the signs and symptoms that come along with that would be headache, stiff neck, light sensitivity, fever, and things like that. And that's how we would define meningitis, not by the cause. And so meningitis can be caused by a whole lot of different bacteria, several different fungi, and a whole lot of different viruses, and that these would all be maybe causing those same signs and symptoms, right? We didn't really talk about septicemia and viremia in this chapter, so we'll move on from that. So exiting the host is your next step. So once you've caused your disease, got in through your portal of entry, you've attached and sat down in your stadium seats and started spraying to other stadium seats. You established your infection. Then we have surviving our host defenses, either by preventing the white blood cells from eating us or living inside the white blood cells, or killing the white blood cells after they eat us, right? Then we have causing the disease through the virulence factors. So a lot of times that'll be toxins, exo or endotoxins, including the endotoxin on gram-negative outer membranes, or exoenzymes that break down our host tissue, adhesion, or break down the mucus, like we see with mucinase and stuff like that. And we've established our infection, and it's got some sort of pattern to it. And then because we're causing the disease and causing the damage in the host, we now have presented with signs and symptoms. And those signs and symptoms may qualify as a syndrome, or they may be associated specifically with that organism, like what we see with influenza or COVID, right? So now we have to get out of our host so we can go to our next host. This could be by the host secreting it through our urination, through defecation, through weeping of wounds and other things like that. That's all sloughing of the skin, and all these things can be involved in spreading the disease, as well as transmission of the blood through vectors like what we see with mosquitoes, or like needles, or sharing needles, and just blood exposure in general. We can have establishment of long-term infection. So you can get an infection and you may or may not have signs or symptoms, but that infection can exist within your body for years without having any signs or symptoms. The period of time when you have the organism infecting you that isn't supposed to be in that spot or shouldn't be there at all, the period of time that that thing exists there and isn't causing any obvious signs or symptoms, that's called latency. And so that can happen, that an organism can live in your body for decades like that, not causing signs or symptoms, but still be established in your body where it shouldn't be. In that sort of a case, like what we see with chickenpox, you get chickenpox, you have your initial acute presentation of the disease, but that virus doesn't go away. It just stays hiding out in your body. And in that time, from when I had chickenpox when I was like 6 years old, and then got over the acute phase, I still have that virus in my body hiding out in my nerves. This whole period from when I was 6 up until today and moving forward, that's my latency period with my chickenpox infection. If you have any long-term effects of an infection, we call that sequelae. So this could be something as simple as scarring, like from chickenpox. If I was 6 years old, I still have scars on my body today from having had chickenpox. Those are sequelae. And then obvious ones like having paralysis that lasts from having polio, or having deafness that lasts from having had meningitis, and things like those are sequelae. So they're lasting effects that we saw from having had the infection. Infection courses are defined in 4 phases. This would include the incubation phase. This is, you don't have any signs or symptoms, all right? But this is where that organism is trying to establish its stadium seats and get adhered to its spot and start multiplying, and the immune system hasn't started reacting to it. No obvious effects of any damage have been recognized by the host or the immune system and things like that. So this can be varying from organism to organism, but like it can take 5 days for you to start presenting with COVID. You get exposed to somebody, and for 5 days, you don't have any signs or symptoms. And then after 5 to 14 days, you can start having signs and symptoms of the disease. And so that period of no signs and symptoms after you've been exposed, that's the incubation period. The prodrome is whenever you have your very first signs and symptoms. It's the initial presentation. So you start getting that tickle in your throat, or you start noticing that you're more tired than you usually are, or you start getting sore, those sorts of things, that your very, very first signs and symptoms, that's your prodrome. The invasion phase, which also in our lecture, we were calling it the acute phase. Once you get to that acute state or invasion state, this is where you have max signs and symptoms. This is where you're presenting with that disease. So you're having all those signs and symptoms that are associated with flu, or all of the signs and symptoms associated with a cold or tuberculosis or whatever it is. So that would be that part of the infection cycle. And then convalescence, this is usually a decrease in the signs and symptoms because that organism's being cleared by the body, or the organism's going into latency and something like that. So you either, or you could be dead from the disease. And this is just honesty there. So at some point, the infection cycle will decrease, either because the person is clearing it or the organism is going into latency. And that's usually because of the body is starting to clear it. And so the organism will go into latency, or it could be because the person died. So that's the convalescent period. Moving on, we have the reservoirs, sources, carriers, and zoonosis. A reservoir is the area in the environment where this organism is maintained naturally. So this could be the bat population for Ebola. So certain bats in tropical areas in sub-Saharan Africa, for example, living in the trees and things like that, they just have Ebola virus naturally, but they don't have any signs or symptoms. They don't have any pathology. They don't have any disease associated with having this virus in their bodies. So that would be a reservoir. You could also think of if you're going camping and you go to a spring or a creek or something like that, and you get water out of it and you drink that water and you end up getting infected with Giardia. So Giardia is an extremely common waterborne pathogen. The reservoir there would be the water. So it's a non-living reservoir. It's just wherever in the environment that this disease is maintained. Wherever you got your disease from is the source. So that would be a specific thing. So if Giardia is maintained in water, then your source would be this creek at this spot in this creek. Okay. So that would be your source. Or if you get infected, like a third of people that have COVID don't have any symptoms, which I say a lot, just to remind you guys that there's people walking out around there right now that don't have any coughs, runny nose, nothing. They are completely asymptomatic. That they could be carriers of COVID. So, carrier is somebody that has the disease. I lost the tip to my pen. Stop playing with it, and I want to lose it. All right. A carrier is somebody that has the disease but does not have any signs or symptoms of it, or they are subclinical, which means that they have very mild signs or symptoms, maybe just a runny nose or slightly little tickle in their throat or something, but they don't really think of it as being an issue as far as going out into public and functioning day to day. But these people are our carriers, and so carriers are individuals or organisms that are having no signs or symptoms, or they might have low signs or symptoms, or they're getting over the disease. They're harboring this disease somehow and spreading it to the population, but they don't have the acute illness, right? They don't have, so basically having, you can't look at them and know you should stay away from them is my point. So that would be our carriers. All right. So zoonosis is a disease that's transmitted, it's maintained within the animal population. They might have signs and symptoms and illness associated with it. Obviously, a rabid raccoon or a rabid coyote, they have the illness, right? They have a pathology associated with having that infection. They have the disease too. And then, but that rabies is maintained within the animal population and then can be spread to humans as well. So that would be considered a zoonosis. And there's a lot of zoonoses out there. So diseases that could potentially come from animals. Anthrax is a great example. It's usually maintained within animal populations. The endospores can hide out in the spores forever. And then anthrax can just exist as disease in like cattle and livestock and things like that. And then humans can become exposed to that through exposure to the animals. Biological versus mechanical vectors. Biological, these guys are actually infected. They may or may not have signs or symptoms associated with that infection. But if they are an organism that is infected with this disease and they can spread it to people, they are biological vectors. Whereas mechanical vectors, they are just like transferring. They are not infected, but this would include things like flies and cockroaches that would get into nasty garbage or would get into poo-poo and then get the bacteria or viruses associated with those environments and then carrying them, transferring them to the human population. And then that would be how we would get sick. And so they are mechanical vectors. They are not infected. They're just transporting. I'm moving on to communicable, contagious, and non-communicable. Communicable means that it can be spread from person to person. Contagious means that it is very communicable. So it's like a level up. All right. So if you can spread a disease from person to person, we consider it communicable. If it is very easily spread and very commonly, and like if you have somebody with the measles, you can bet on them spreading it to somebody else that isn't vaccinated. It's a very contagious disease. Non-communicable, the good example that I had of this one is that if I have a urinary tract infection, that doesn't spread from person to person. That's usually that person has that urinary tract infection. I don't know why you would be taking my infected urine and putting it into your urinary tract. I'm sure you could force a urinary tract infection that way, but that through our natural practices and living situations and hygiene practices and things like that in our society, that is a non-communicable disease. Okay. So horizontal transmission is like person to person, whereas we would distinguish these guys from one another. Okay. So vertical transmission is from parent to child. So this could be a disease that is inherited from the sperm or a disease inherited from the egg, or it could be a disease that is transmitted through the birth canal or through the breast milk. And so you could be born completely free of that disease, and then exposure to the breast milk could transfer, like HIV, for example, could transfer through the breast milk. And that would be vertical transmission. Horizontal transmission is like if you got COVID from me. So that's not a mother to child or father to child sort of transmission. If a father got COVID and transmitted that COVID to his children, that is still horizontal transmission, because vertical transmission depends on that sort of direct biological parent connection. Okay. So I want to be very clear about that. Vertical means that it's related to that parental biological connection. So birth, breast milk, that sort of stuff, or literal genetic transfer stuff. All right. So vehicles are things by which we are spreading our disease. A fomite is an inanimate object that is only transiently contaminated with an infectious particle, let's say, and then that is how the next person gets infected. So the pen that I'm handling right now, if I had COVID, the virus could get stuck to the pen. You could come and use the pen and then get COVID when you touch your mouth or your eyes or something like that after touching the pen. So the pen would be a fomite in that example. So these doorknobs are great examples. Handles on like sinks, those sorts of things are great examples of fomites. Oral fecal route, obviously having contamination from having defecated poop, and then you have the feces that's contaminated with the pathogen, through your hygiene or lack of hygiene practices. Your hands become contaminated and you're not washing your hands, and you can spread that through fomites or through direct contact and things like that. So if it's related to having come from excrement, and then getting into the mouth due to us touching our face and our mouth all the time, that would be oral fecal transmission. Not washing your hands before you eat, not washing your hands before you prepare food that somebody else is going to eat. That's oral fecal transmission. We can get diseases from our water and our soil. We've already talked about Giardia coming from our water. Leptospirosis comes from the urine of infected animals that is then like deposited into the soil, and then people could contact the soil, or animals could contact the soil. As well as things like anthrax being harbored within the soil, the endospores from anthrax or endospores from tetanus and things like that being harbored in the soil. Air means droplet nuclei and aerosols. Here, when you sneeze or you cough, we have water droplets that can harbor the infectious particles. So pathogens can be transmitted that way. They can also dry onto surfaces, and then that could be transmitted from contacting those dried particles as well. Koch, Robert Koch was a guy that came up with these steps that we call Koch's postulates that are used to identify the cause of disease. An organism that caused the disease is called the etiological agent. The etiology of a disease deals with how that disease was caused. So an etiological agent is the agent that caused the disease. So whenever people started coming around with these respiratory symptoms and these systemic sort of symptoms that we associate now with COVID disease, the etiological agent for that was the SARS-CoV-2 virus. Okay. That sort of stuff. Or if you have meningitis, which we've already decided that was, you've already talked about how that is a syndrome, that if you have meningitis, what is the etiological agent of that meningitis? And then we might decide that it is Streptococcus pneumoniae, the number one cause of meningitis, which is a bacteria. It could be that is your etiological agent, or it could be your etiological agent is some kind of virus that you had, like measles, which can lead to meningitis and death. And I want to be very clear about that. We've already had deaths in Texas from this measles outbreak. Okay, so I have to, hold on. I'm trying to go to the next slide, and it's like, all right, here we go. All right, so let's move on to chapter 14. Chapter 14, we had basically gone over Florence Nightingale and John Snow. These guys were involved in, basically, they were pioneers of epidemiology, looking at the spread of disease, determining the causes and the factors that are involved in the spreading of the disease, and then trying to put an end to the spread of the disease as a response to the data that they collected. Florence Nightingale, during the Crimean War, she noticed that there were soldiers coming in with stab wounds that were ending up dying from dysentery. It was actually a very high proportion of the soldiers that were dying of dysentery. Dysentery is not transmitted through stab wounds. And so why were these people getting dysentery? Dysentery is bloody diarrhea, by the way. So why were they getting GI illnesses? And so what she found out was that the healthcare workers at the hospital that were taking care of these injured soldiers were not washing their hands. And so, basically talking about transmission of gut bacteria to these other already injured soldiers. And so she instituted proper hygiene practices like washing hands and cleaning their environment in order to prevent the spread, and significantly decreased the spread of disease. And she is considered the mother of nursing because of that. And we have John Snow. He was involved in a cholera epidemic in London. And what he noticed was that when he mapped out the cases that were coming out with cholera, he mapped each new case and noticed that these cases were centered around a water pump. And what he found is that the people that were getting water from that water pump were getting cholera. And so he basically took the handle off of that water pump and made it so people couldn't use it anymore. And it stopped the spread of cholera. So he's considered the father of epidemiology for those discoveries. Epidemiology is the study of the spread of disease. It's the 5 W's, basically the who, what, where, when, how, why sort of spread of disease, and try to figure out why it's spreading, how it's spreading, and then essentially using that information to control the spread or at least monitor it where possible. Prevalence versus incidence for the purpose of our course. Prevalence is talking about the totals in an outbreak. So how many people are being affected overall in the total population. Whereas incidence is talking about a particular period of time. So this would be like cases per week or something. All right, so that's what incidence. So if we're focusing on a particular period of time, mortality rate versus morbidity rate. Morbidity rate is the same thing as incidence. They're the same. So the morbidity rate, we can think of something as being morbid. We might think of it as being a dark idea or whatever. So it's sort of like that. We haven't progressed to death yet, but it is, that sort of idea. So if you are sick, if you're having these symptoms, that's morbidity. If you die from it, that's mortality. So mortality is the death rate from the disease. This would include some measurements such as our case fatality rate, which is later on in the chapter. But death rate, that's mortality rate. Disease rate, that's morbidity rate. And morbidity rate is the same thing as incidence. So it's always going to be in a period of time. So how many cases were in the week? How many cases were in the month? That is the morbidity rate or the incidence. There's different kinds of epidemic outbreaks that we can see. In a point source epidemic, people were exposed to one source of infection at a single instance in time. So you go to the fair and somebody's walking around with the flu, and you get exposed to the flu and you get the flu. You were exposed at that point in time from that person. It's one source, one point in time. That's a point source epidemic. Okay. And then we have point source epidemic. Then we have common source. This means that people are getting sick from the same source, but it doesn't have to be all at one time. So that good example that we have for that was that cholera epidemic with John Snow. People didn't get all sick all at one instant in time, but they did all get sick from that one water pump. But people were visiting it over, days and days. So that's a common source. They all got sick from a common source, but not from exposure at a single point in time. It's over, vague amount of time. Okay. Then we have propagated epidemics, and propagated epidemics, these are being sustained by the population since the initial exposure. So the example here would, of course, be COVID. We are sustaining COVID now in our population, and we might get new strains because of that sustainment, but that we are sustaining our outbreak within society. We'll have, moments where we have higher incidence, right, of this illness, but that's going to be fluctuating maybe based on season or how much time people are spending together or when and where and how and all of that. But it is still being maintained within the population. So when you have an outbreak of Ebola, this is typically going to be just an outbreak, and it's going to be not necessarily maintained within the population continuously after that, right? It's usually going to die out on its own because people know to stay away from somebody that's bleeding out of their orifices. So that won't be maintained within the population. In order for another outbreak of Ebola to occur, you'll have to have another exposure to it. So flu, cold, COVID, all being maintained within the human population. Those are propagated epidemics. An epidemic versus endemic versus sporadic versus pandemics. Endemic means that it already exists steadily in your locale, in your area. So nobody would be surprised if we had a few cases of cold here or there. Right? So it is endemic in the human population in general. It's endemic even here in Oklahoma. These are things that you wouldn't be too surprised to see. If you go to sub-Saharan Africa and people had malaria, that is endemic to those areas. They are used to seeing that. It's a commonly steady in those areas. That's endemic. It's established in those areas. Sporadic, it would be just one of those random exposure incidents. So getting bitten by a raccoon and getting rabies would be a sporadic, right? This isn't an epidemic. Epidemic means it exceeds the amount that is what is expected in the population. If it exceeds what is endemic to that area, now we've become epidemic. There are numbers and levels that you'd have to reach at in order to be seen as epidemic, but that's not within the scope of this course. That would be defined by each illness. But essentially, epidemic is exceeding the prevalence of what is expected. If here in Oklahoma, we expect to see, let's just say hypothetically, like 10 colds every month, then if we started seeing cases where we started having 2,000 people get a cold this month, that would be an epidemic. All right. Pandemic is when you cross continents. That's it. If the spread of the disease has crossed a continent, if it's an epidemic and has spread across continents, then that is a pandemic. Sorry, I had to get some water. All right, screening. We like to screen our diseases. There's different kind of diagnostic tests, and we'll go over the different types of the tests themselves when we get to chapter 18. But a lot of these diseases we will screen for, and that just means using cost-effective, quick, easy tests to just say whether or not we think it's likely that this person has this disease. For example, COVID home screening tests. If you take one of those home screening tests and you're positive, you have COVID. If you take a home screening test and you're negative, you might not have COVID, but it's not 100% certain, right? They say if you're still having signs and symptoms, test it again in 48 hours. And if you're still having signs and symptoms, then go to the doctor and get a PCR test, because those are going to be more accurate, but they're also more pricey. And they're typically a lot of times diagnostic tests that are definitive at like doctor's offices and things like that. Typically, those true diagnostic tests are going to be more invasive as well. So for example, with pap smears are a screening test. We're looking for the likelihood that you may or may not have cervical cancer. And so we'll do the scraping of the cervix and we don't see any cancer. That doesn't mean you're ruled out forever and ever of not having cancer. But if we saw the cancer there, we would know, hey, time to get more in depth with the treatment and things like that. So screening tests are made for that. There's two basic aspects of screening that we would want to be aware of: the specificity and the sensitivity. These are basically dealing with the likelihoods of false positives and false negatives. And so they require a little bit more explanation in order to understand how they work. And I always start with explaining sensitivity because most people get that idea. Sensitivity, the goal of increasing the sensitivity of your test. The more sensitive that a test is, the less likely false negatives will be. And what this is referring to is a false negative is whenever you test negative, but you're actually positive. All right. So when you take your home test for COVID and you test negative for COVID on your home test, but you actually had COVID, the test just didn't pick it up, that's a false negative. And so the higher the sensitivity of a test, the less likely a false negative. So we want to have a test be as sensitive as possible, right? You want to pick up all the positives that are there. If you're a very sensitive person, you're going to pick up on all the social cues, right? The more sensitive you are as a person, the more you're going to pick up on the social cues. Same thing with this guy. The more sensitive the test, the more you're going to pick up on the positives that are there. You want to identify all of the positives, even the very weak ones, so that you don't have any false negatives. With specificity over here, this one is dealing with false positives. So calling something positive when it's not. This could happen because the test that you're using sees the shape of, flu protein, which maybe flu protein looks pretty similar to the cold virus protein. And so you call it positive, but this person doesn't have flu, they have a cold. All right, so there's tests that work that way. And this might be based on signs and symptoms, or it could be based on the actual proteins on these organisms, or the fact that your antibody that you have in your bloodstream that should be seeing flu, you have antibodies that see something else in your bloodstream that happens to react with the flu test that they're doing. So just things like that. So it's usually due to some sort of cross-reactivity or similarity in these organisms. So specificity says you want to be specific for the thing that you're looking for. You don't want to say that this person is positive for this disease when they actually had a different disease that just looked like it. If you're testing for COVID, you want to be sure you're testing positive for COVID and not popping positive on that test when what you really have is the flu, for example. So specificity is eliminating false positives as much as possible. Sensitivity is eliminating false negatives as much as possible. All right, moving on. In epidemiology, we'll do studies to try to figure out what is causing these infections. A correlation might be if you walk into a room, so correlation versus causation, really quick. If you walk into a room and you see there's a dead body on the floor and a person standing next to it with blood on their hands, thinking that that person that's standing there killed the dead person is a correlation, right? You have to prove that that person actually killed that person because they could have just been there circumstantially. So correlation is seeing that there is something, that these things are tied together somehow, but finding the actual cause, we need to do studies to determine causes. So these are studies that are used to investigate infections, looking for correlations and causations. The cross-sectional study. This is taking data, usually from whether people have disease or not, and then maybe whether or not how they were exposed, but taking data from that point in time. So coming into a group of people that got COVID, right? And then taking all the data for how they were maybe be exposed to certain things versus whether or not they have the disease, and collecting that information from this population that you got from this one point in time. So we're not taking intentionally a group of people that don't have the disease and intentionally a separate group of people that have the disease and comparing them. We're taking all the people at this point in time. So we're taking a cross section of a population indiscriminately. Okay, so a cross section and then collecting the data from that cross section. A case control study is exactly what I was talking on the flip side. Taking groups of people that have this disease, those are your cases, and a group of people that don't have the disease, those are your control group, and getting those groups on purpose. On purpose, the people that have the disease, on purpose, the people that don't have the disease, and then comparing them. That's a case control study. Not just taking a group of people at the point in time and then dividing out the data, which is cross-sectional, but intentionally looking at the cases and intentionally looking at the control group. Don't have the cases, okay? Don't have the disease. Then we have the cohort study. In the cohort study, you're looking at a group of people that maybe smoke and maybe a group of people that don't smoke. So they have indicators that you want to follow over time. None of these people have disease. So in a cohort study, nobody has disease, and we're tracking these groups of people over time to see if they get the disease. And they have predictors typically. So, like smokers, you predict they're going to get lung cancer more commonly than people that don't smoke. That would be a cohort study. And these are usually done over a long period of time. With epidemiology, we also want to track infections that are associated with being in a hospital. And there are several different types of infections that are associated with being in a hospital, whether that is catheter associated infections. So getting catheters, inserting something into a hole into somebody's body has a likelihood of introducing bacteria, especially the bacteria that are near the area that don't belong in the area. Then we have like central line infections. So maintaining an open port in somebody's body, and your bloodstream is supposed to be completely sterile. There should not be any microorganisms in your bloodstream at all. So there is a high likelihood of introducing microbes. You're talking about a bloodstream that has no microbes. Guess what the bloodstream is to microbes? An open stadium. It's an open stadium. There is nobody sitting in those seats, and there's plenty of seats. Nobody's sitting in them. So to a microbe, that is like, wonderful opportunity. It's the land of opportunity. So introducing any microbes through that central line access, that's an example of a situation that is pretty commonly seen in hospitals. We also have respirator-associated infections. It's a similar concept. It's just a way of, these people are already not ambulatory. They can't get up and walk around and get their lymph moving around, which we'll talk about the importance of moving your lymph and therefore your white blood cell response when we get into chapter 15. But getting up and moving around to pump your lymph, being able to cough up, fluid that collects in the lungs, and therefore the microbes that are associated there. Coughing is a very common way of clearing out microbes in your respiratory tract, and these people can't cough. So we get fluid settling in their lungs, their immune system isn't functioning optimally, and all these things that can predispose you to the bacteria, plus maintenance of the sterility of that equipment is near impossible. And so we have illness associated with that, plus the obvious one of surgical incision infections. And we have infection control officers that are in charge of maintaining policies and procedures and dealing with these types of infections that we see associated with the hospital environment. Next, we have R naught. R naught is a measure of how many people an infected person will infect. So when you get COVID, how many people are you likely to infect? And that number is called R naught. So, or R sub zero. And this is basically referring to the transmissibility of this disease. So this how easily spread it is. So contagiousness, if you will. So with COVID right now, I believe the number is somewhere around 5. You're likely to infect 5 people if you get COVID. And this number is unique to every disease, and it's calculated for every disease and every strain within that disease. So that's how easily spread it is. The case fatality rate is a measure of, if you get the disease, how likely you would be to die from it without treatment. So I want to make that very clear. Case fatality rate is a measure of death rate if you get the disease. So if you have the infection, the likelihood that you're going to die without treatment. So with HIV, which was one of our other examples earlier on in the semester, your likelihood of dying from HIV if you don't get treatment is 100%. So that's the case fatality rate for this. For HIV, the case fatality rate is 100%. Right? This is without treatment. Treatment changes those things, but we want to be sure that we're looking at the face value of these things. If treatment stops working, we know what kind of disease we're still working with, right? So that's what the importance of the case fatality rate. Herd immunity deals with how many people need to be vaccinated in order to effectively protect the unvaccinated populations. So with measles, we're talking about 95 to 97, I think, percent of the population needs to be, I think it's 97% of the population needs to be vaccinated, or in order to protect the other 3% of the population. The population includes little babies that don't have the ability to form an immune system yet. So if they're under 6 months old, you forget them having an immune response. So they can just get these infections. So we're talking about people who don't have an operable immune system, including little babies or people with genetic abnormalities in their immune system, which is more common than you might realize. And then older folks whose immune systems are failing them, these people can't get vaccinated. So 97% of the population needs to be adequately vaccinated, have a proper immune response, and be immune to this disease in order to protect the slews of people who cannot do that for themselves. So in little babies and the people with the deficiencies in their genetics and the old people, 97% of the population needs to be vaccinated to protect those people from getting infected from measles, which is why we're seeing outbreaks in our area, in Oklahoma, in Texas, and people getting sick, and you can easily die from these things. All right, moving on. That's herd immunity. We didn't go over this in our lecture, so I'm going to mark it out. But if you are interested, the government has set up several programs for COVID vaccinations that if you did have negative effects associated with COVID vaccination, and then they have different programs that are set in place for other kinds of vaccinations, you can report this to the government. And if you do have injury or disease associated with having gotten a certain vaccine and it is related to the vaccine itself, then you may be eligible for compensation. I sound like an infomercial, but it's true. Right, emerging diseases are diseases that are new to the population. A re-emerging disease is something that we had seen previously in the past in our population and is now coming out again in our population. This is true of tuberculosis, for example. But tuberculosis was a very old disease, and now we are seeing increased outbreak with that. But that can be associated with, more with COVID coming out, with increased homeless populations, and with increase in the housing crisis. So people are living in areas where they're now more close confined with other people and things like that, but it's still a re-emerging disease. Neglected parasitic infections include all of like our helminths and protozoa infections that are less commonly seen in affluent populations. So these are pretty common in third world countries as well as in poorer populations, even in our developed countries. This would include things like toxoplasmosis, which is the disease that's spread from handling kitty litter. Cats maintain them as a reservoir. Cats can, again, be a reservoir for these diseases. They don't have signs or symptoms, but they're harboring the protozoa, and then you can get exposed to that, and that can lead to signs and symptoms associated with toxoplasmosis. Chagas disease, spread by the bite of an insect. Neurocysticercosis, which is tapeworms getting in your brain, and then trichomonas, which is a sexually transmitted protozoan infection. It's extremely common. And I want to be very clear that it's so common that it's not even a reportable disease. Like the CDC doesn't even track it anymore because it's just so common. So these are all diseases that are common here in the United States. And believe me when I tell you there are plenty others, like the ones that we did our eukaryote labs on, that are associated more with third world countries like ascariasis and things like that. So, all right, that is our summary of our chapters. So now let's move on to our most commonly missed topics. Let's start with chapter 13. Chapter 13, one of the most commonly missed topics is understanding what a true pathogen is. A true pathogen, these are microorganisms that can cause disease in healthy individuals that have fully functioning immune systems. Normally, whenever you're exposed to these pathogens, your immune system will see them and be able to clear them before, like for transient pathogens, let me restart this explanation. With true pathogens, they will cause disease even in healthy individuals. Your immune system might be able to get rid of them eventually, but almost everybody who, even if they're healthy, will have presentation of signs, symptoms, and disease. So that's what a true pathogen is. And these guys, that's what they do, is be a true pathogen, typically. So with tuberculosis, this isn't something that hides out in like your colon, and then if it gets exposed to your lungs, it causes disease. This is something that isn't part of your body. It's not something that just usually is transient, and then we just have a special situation where it can cause disease. It's something that causes disease. COVID, it causes disease. Flu, it causes disease. Does E. coli always cause disease? No. It's only whenever it moves to areas where it doesn't belong, or when we have very pathogenic strains of E. coli. So true pathogens, these are guys that cause disease even in healthy people, versus an opportunistic pathogen down here. These are organisms that exist normally in our environment that our body should be able to clear out, or they exist somewhere normally in your body that don't belong in other areas of your body. And only when they go to areas they don't belong could they potentially cause disease. So they take the opportunity, but they normally just exist just fine with you. You coexist fine with our opportunistic pathogens, and you can expose yourself to them regularly. But if you set up the perfect opportunity, then they can cause disease. So understand that true pathogens are going to be always like associated with creating infection and disease. Let's move on to our questions involved. Which of the following is a characteristic of a true pathogen? So we know true pathogens, these are the guys that are always involved in causing disease, even in healthy people. All right. So true pathogens, do they cause disease only in people with weakened immune systems? No, they can, but they'll also cause disease in healthy people. Do they require a high infectious dose to cause the disease? No. So this isn't a qualifying factor for true pathogens. These are organisms that you can see them even in a small amount. For example, COVID, you get one freaking virus. Is one infectious dose is a measure of the amount of organisms that you need to be exposed to in order to cause disease. That was covered in the lecture. So infectious dose of one for COVID, you only need one virus particle. Is that a high infectious dose? No, but this guy is a true pathogen. And even with just one viral particle, healthy people can still get sick. Do they possess specific virulence factors that enable them to overcome host defenses? Possibly. This could be some aspect of our disease causing guys. They usually have traits that make them able to be a true pathogen. And then our last choice is they are harmless and only cause disease in unhealthy individuals. No, they cause it in even healthy people. So, yes, these guys have specific virulence factors that enable them to be successful with all these categories that we discussed previously in chapter 13. All of these things from portal of entry all the way to exiting the host, they have virulence factors that help them to establish the disease in order for them to be true pathogens. Our second question, in patients with a robust immune system, so healthy people, which of the following all organisms, we're talking about healthy people, which of the following organisms would be classified as a true pathogen, which we have defined up at the top, due to its ability to cause disease independently of that host immune status? So it's saying, even if you have a healthy immune system, which of these organisms would be able to be classified as a true pathogen, something that causes disease, even in healthy people? So we have some explanations associated with these. Luckily, you don't have to just know it off the top of your head. Would it be Pseudomonas aeruginosa, which is a common opportunistic pathogen? What's already telling us it's opportunistic, it's not a true pathogen. Pseudomonas aeruginosa lives very commonly in our environment all around us. Would it be Candida albicans? Candida albicans, Candida, or what causes our yeast infection. It's a very common populant of your body right now. You have it in your sinus cavity, you have it in your nose, your throat, and then often in your genital tract and folds of skin all over. It's part of your microbiome. So this would not be a true pathogen. It can exist naturally on healthy people and not cause disease. True pathogens, if they're existing on a healthy person, they cause disease. So it's not going to be that. Mycobacterium tuberculosis. If Mycobacterium tuberculosis, it has developed an infection in a healthy person, it causes disease. So this is a true pathogen. We already have discussed it as a true pathogen. And then Aspergillus fumigatus, Aspergillus, just like we looked at in our microscopes. This is typically an opportunistic pathogen, something that exists in our environment. We usually see it and our body doesn't get disease from it. That means that it's not a true pathogen. All right, next topic for chapter 13, virulence and virulence factors. Virulence is defined as the degree of pathogenicity, also known as how bad the disease is. Whereas a virulence factor is anything that helps the organism cause disease. This could be things like adhesion factors, things that help the organism to adhere better. Certain strains of certain strains of E. coli have special fimbriae that attach better than other strains of E. coli. So we call these diffusely adherent. So these adherent E. coli are better at causing urinary tract infections than normal E. coli, for example. So that's an adhesion factor that works as a virulence factor, helps to cause disease. Invasive enzymes, enzymes that help the organism break down aspects of how your tissues are held together so they can get deeper in. The example here is hyaluronidase that breaks down your hyaluronic acid that is part of your extracellular matrix. Matrix breakdown. And that leads to getting deeper in the tissues. Toxins, these are molecules that lead to damage of the host somehow and can interfere with normal processes of the host. These could be exotoxins secreted by the bacteria or endotoxin, which is the molecule LPS, lipopolysaccharide, that is part of the outer membrane of gram-negative bacteria. And then we have immune evasion mechanisms, anything that helps it evade the immune response. And there's a lot of these. And we'll go over these in a little bit more detail in later chapters, but anything that would help them. So this, we know capsules help evade our white blood cells eating them. That makes it an immune evasion mechanism. We can also have organisms that can change their surface proteins. So while our body is trying to say, I see this protein as foreign, let's make antibodies against this protein. And then it switches it up and it doesn't have that anymore. And so those antibodies don't work anymore. And so a lot of these organisms can change that up pretty willingly. All right, so let's move on to our questions for this one. So we know virulence is how bad is the disease? And then virulence factor is anything that helps the pathogen cause the disease. So we'll make our little notes first. All right. So which of the following best describes a virulence factor? Is it a substance produced by a pathogen that helps it adhere to host tissues? Possibly. Is it a type of immune cell that helps the host defend against pathogens? A virulence factor is something that the pathogen makes that helps it cause disease. So it's not an immune cell made by the host. Is it a measure of the number of pathogens required to cause disease? No, these are factors of that pathogen that allows it to cause disease. The number of pathogens needed to cause a disease is called the infectious dose. Also described in this chapter. A method, or is the virulence factor a method used by the host to clear pathogens from the body? No, it is something that the pathogen has that helps it cause disease. And our best answer here would be something like that would help with adhering to our host tissues. All right, our next question. In a patient with a severe infection caused by Clostridium tetani, so we've got tetanus going on, which virulence factor, so which aspect of tetanus helps it to cause disease, is primarily responsible for disease symptoms such as muscle spasms and rigidity? Well, here's some things about the organism. Would it be its anaerobic respiration? So this has to do with its ability to make ATP without oxygen. So this is just an aspect of the organism in general. This is not a virulence factor. This doesn't lead to its ability to cause the disease symptoms, the damage, and the presentation of the disease, right? This is just the ability of this organism just to be alive. So it shouldn't be this. Same thing with DNA replication. This is something that the cells just have to do to replicate. The ability to replicate your DNA isn't associated with causing the disease, but it's toxin that it makes. This probably is going to be it, right? This toxin and the fact that this toxin is leading to muscle spasms and rigidity, which is what we call spastic paralysis. You can't use your muscles anymore because they're tensed up. Flaccid paralysis, you can't use your muscles anymore because they can't contract, right? So this is spastic paralysis. Anyways, and then moving on, could it be the co-transcriptional translation? This is the fact that we can make protein at the same time that we're still making our mRNA. Bacteria can do this because they don't have a nucleus. This is just, again, their reproductive, normal making copies of the cell thing. So our answer here is our tetanospasmin toxin. This is something that is specific to this organism that helps in its development of the disease. All right, next topic. This is not chapter 4, this is chapter 13. Endotoxin. Endotoxin and exotoxins. Endotoxin is always going to be, let's put specific, endotoxin is always going to be LPS or lipopolysaccharide, which is a molecule on the surface of the gram-negative outer membrane. Always. That's what endotoxin is. Exotoxins are toxins, so they are damaging molecules secreted outside, that's why they're called exo, of the pathogen. All right. And we have some more description of these if you need it to go into a little more detail. I'm going to go ahead and move on. But anything that's secreted by those cells outside of the cells that leads to damage of the host is an exotoxin. Endotoxin, it's always LPS on the outer membrane of gram-negative cells. So here's our question. Which of the following statements accurately distinguishes endotoxin from exotoxin? So we'll write it up here real quick again, just to remind ourselves. Endotoxin, LPS on gram-negatives. Exotoxins, they cause damage and they're secreted outside of the cell. Okay. So here's our choices. Endotoxin are proteins secreted by bacteria, or that's not true. Endotoxin is part of that gram-negative cell, so it's not secreted. So we can already move on. Endotoxins are released only upon lysis. So this is something interesting. So now we're saying that endotoxin could be something that when we break up our gram-negative cells, will end up getting released. So maybe. So we'll read the rest of this. While exotoxins are actively secreted. So far, this might be an option. Let's move on to our other choices. Exotoxins are heat stable or endotoxins are heat labile. We don't have to know this for our class. So don't worry about this. All right. But when we come over here, I believe it says it in this explanation that endotoxin is heat stable. And then exotoxins are heat labile. We do not have to know that for this class. Okay. But this happens to be the opposite of what that said. So that was wrong. And hey, we're going to mark it off because we didn't talk about it in our class. Okay. Endotoxins are, so we're really just having to choose between A, B, sorry, and D. Endo inside target specific cells or processes, while exo cause systemic effects. So we've actually already talked about how endotoxin causes systemic effects. It causes that widespread shock response, right? Exotoxins, we've already said, given examples of an exotoxin, like botulinum toxin, that specifically is associated with blocking our acetylcholine release. It's a very specific mechanism and process that they target. So this is the opposite of that, what we've talked about. So B is our answer here. Because the endotoxin that is part of that outer membrane is part of that outer membrane, it gets released into the bloodstream whenever we have dead gram-negatives. But the exotoxins are actively secreted by those cells. All right, next question. In a patient presenting with septic shock, they're having septic shock, which is something that we can see when we have broken down gram-negatives releasing their endotoxin. Right. There are septic shock. They have gram-negative. That makes sense. So we're already thinking endotoxin. Which type of toxin is primarily responsible for this systemic sort of effect? Septic shock. It's associated with gram negatives. All right, so we're already being able to go find some. Is it exotoxin? Probably. Probably not. We think it's endotoxin because it's associated with the gram negatives. When we're not targeting specific tissues, we're having a systemic effect. Is it endotoxin because we're triggering a systemic inflammatory response and release of cytokines, which we'll learn more about what these are in the later chapters? Might be this one. Is it exotoxin because we have heat stable damage? No, we're not talking about anything to do with that. And then endotoxin directly interferes with host cellular metabolism. Are we talking about the effect dealing with cellular metabolism, or are we talking about a systemic effect associated with basically the whole body having this leading to the septic shock response? So it's not this one, so it's going to be B. All right, moving on. Another one from chapter 13. A syndrome is a set of signs and symptoms. All right. So a sign is anything that you can objectively measure. So signs are measurable or verifiable. And then a symptom is subjective or reported. Like pain, fatigue, has dizziness on here, nausea, tiredness. I guess tiredness is fatigue, but yeah. So these things, the things that will be reported. All right, so we're going to move on to our questions. What defines a syndrome in medical terms? So we know a syndrome, you are defined by your set of signs and symptoms. All right, so let's see if what our choices align with this. Would it be a single symptom? No, it's a set of signs and symptoms. Would it be a combination of signs and symptoms that occur together and are characteristic of a condition? This one's looking pretty good. Would it be a genetic mutation that causes a very rare disorder? No. Typically, this is a syndrome is something that is a generally described thing. Is it a diagnostic test? It's not a diagnostic test. It is a set of signs and symptoms. So it is a way of describing an illness, right? So this would be B. Our next question, in a patient presenting with a combination of symptoms such as photophobia, headache, stiff neck, and fever, which we've already brought this up many times, that this is already indicating in my mind, I'm thinking meningitis right off the bat. That these are signs and symptoms associated with meningitis. So did that indicate to you that this could be Down syndrome? So Down syndrome, we know is associated with genetic defects, but it is a syndrome. It's defined by its signs and symptoms. Down syndrome is not defined by the genetic defect. It's defined by its signs and symptoms. But this isn't that, right? Is this influenza? Does influenza have photophobia, headache, stiff neck, and fever? It's not associated to, it could potentially have like, headache or a fever associated with it, but influenza is not a syndrome. It is a specific disease caused by a specific organism. Common cold is a syndrome, but it doesn't have these signs and symptoms, but meningitis does. It's caused by a multitude of things, but it's defined by its signs and symptoms. All right, chapter 14's most commonly missed topics. Of course, it's going to be these studies that are done in epidemiology. Our case control study, looking at basically cases. So case control, we have the infected versus the not infected. For a cohort study, we have a long-term study of people without the disease who do have predictors or don't. Comparing groups of people that have the predictors versus a group of people that doesn't have the predictors, and then seeing if they get the disease, but nobody has it to begin with. And then cross-sectional, basically looking at the disease, whether people have the disease and how they were exposed from a cross-section of the population. So just taking random people and then saying, do they have the disease and where and how were exposed? But we're not looking at people that do have the disease and don't have the disease specifically. We didn't start off with do have the disease and don't have the disease. We're starting off with random population of people and then asking, do they have the disease or not? How were they exposed or not? Okay. Okay. Taking cross section that way. So that's our basic explanation. And there are some more outlined differences on these if you guys want to take some time to go over those. But well, let's move into our questions. I'm going to put our little cheat sheet out at the side of case control. Those that have the disease versus those that don't. We have our cohort, long-term study. Nobody has disease yet and looking to see over time if they get it. And then we have a group of people that are having a predictor or don't have the predictor. That's cohort. I don't know why it won't let me write over there anymore, but cohort. And then we have, sorry, cross-sectional. And this is taking a random sample of the population and then asking the question if they have the disease or how, or if they were, how or when they ever had an exposure event. All right, so let's look at our questions now. Which type of epidemiological study involves following a group of individuals over time? So we're already kind of hinting at it probably is the cohort one, right? To observe the development of the outcomes based on their exposure status. So this is our predictor. So we're looking at predictors and we're looking to see if they get the disease. They don't have it yet. So this suggests to me this is going to be the cohort study because the case control study, looking at people who have the disease versus those who don't, that's not what's happening here. And cross-sectional study, just taking a random set of population and then if they have the disease or don't have the disease after getting that random population, or if they were exposed or weren't exposed, looking at that. So we are looking at their exposure status in that situation, but we're not starting off with them not having the disease and then seeing if they get it, right? All right. And this is not a randomized controlled trial in this case. We are literally specifically picking people that don't have the disease and looking at two populations of them. Do they have this exposure status or don't they have this exposure status? This is not randomized and it is controlled, but it's not randomized that way. All right. A researcher is investigating the association between smoking. This is a predictor. This is our exposure status. That's our predictor here. And then whether or not they are likely to develop lung cancer. So they don't have lung cancer yet, right? And then we're going to look at them over a period of 10 years. So again, long-term, nobody has the disease yet. And we are starting off with our exposure status, which is our predictor here. Which of these three types of studies would be appropriate for this? This is, again, our cohort study, because our case control, we would have been having people that had the disease and the people that don't have it. Here we have only people that don't have it yet. This is not a cross-sectional study. We're not taking a random population and then saying, okay, those of you from this random population who has the disease and how were you exposed or not? That's not what's going on here. Right, we're following people that do not have it, and we're following them over a long period of time. Case report is not one of the things that we learned about, as far as these are not one of the common three types of these guys, okay? So that is it for our review today. Does anybody have any questions for me before we call it quits? Let's see who we have. All right. So if you guys don't have any questions for me, I'm going to call it quits for the day and go ahead and log off on this. If you guys are studying and you have any questions about this or anything from Unit 2, please feel free to email me and I will be happy to help you. Thank you for joining me today, folks. And I will, yeah, happy to do it. And I'll see you guys hopefully on Sunday at 6 p.m. if you can make it.